Thank you, and good morning to everyone. I know it's very early on. Thank you to the Italian friends for making us wake up at 6. So, when Francesca asked me to talk about something, I wanted to talk about my biggest passion, and that's evaluating lenticular surgery. But then, not everyone is a lenticular surgeon or is interested in that. So, I decided to make something else and talk about how we use CSO to make decisions in some difficult cases. So this is a type of case that we all fear. It's a patient that we had done previous LASIK on, and they come back 10 years after and they have ectasia. Now, my friend Juan here is going to say CARES, and I will agree that CARES is the future to solving these things, but until it's available for all of us, this is how we fix this. So we have a patient who had an eventful microkeratom LASIK in 2013. She was great, and her last follow-up was day 30. She comes back 10 years later with very bad vision, and you can see here how the cone looks, and you can see that it's quite thin. So one of the main things that I always like to do is I don't just look at the K values. I try to look at the shape. And I focus on the elevation maps as much as I can to understand what the patient is talking about. And the other thing that I like doing, especially with patients with keratoconus or anything else like it, is I like this applanation-like view to tell the patient that their disease isn't on the front of the cornea, it's on the back. We just see it on the front. And this helps them understand that there is more than our surgery as a part of this. So it's a good tool to we did the laser on the front, but the problem is from the back. So it kind of helps them understand that it could have something related to us. I know it's not really true, but it helps them understand it. But what I like is, I like this. I like to create this map for them, and I like to take the pupil plane and create a gradient to see how much of a gradient there is between the points on the pupil. So in this case, you have 13 diopters of change and a total of 3 degrees of diopters per millimeter. So every millimeter on their cornea equates to an additional 3 degrees of keratometry. That is not acceptable vision. And using the Osiris, we often use the visual simulation of the optical quality to talk to the patient, because this patient, she might be 20/30, but this is an unacceptable quality of vision. And even when you look at the glass power here, it's quite high. So what we do is we focus on just the higher orders. We don't consider the low orders here. We don't care about them. We can fix them with an ICL, with an IOL, or a soft contact, and even glasses. So we focus on the high orders. The plan is simple. We tell the patient that they have surgically caused ectasia. We tell them the situation is not good, and we tell them there's 3 options: scleral, pure cross-linking, and cross-linking with PRK to try and help. I know Bart would not fully agree with you, but this is what we did in this case. So yes, we like the range time view here, so we measure the flap in multiple locations. And what we do is we consider the flap as free tissue. It doesn't do anything for the biomechanics of the eye, so the entire thickness of the flap is available to make the eye better. So as said, biomechanically, the flap is useless. So this is the plan, 49 seconds on the Amaris. And this is the change in topography that we achieved in this eye. On the left, you can see the axial maps. On the right, you can see the tangential maps, and you can see a huge difference. How does this difference look for the thickness of her cornea? Just 61 microns, but the flap was 110. So we stayed within the flap. The topos on the elevation, there's a huge difference again, white normalized. And if you look at the wavefront change, the total pose went from 5.3 to 2.57. So it's a huge change in the higher orders. And the other case is a Pseudomonas scar. It's a 27-year-old guy. He's an orthopedic surgeon. You know, they're not the smartest, so he wore his contact lenses in a swimming pool, ended up with a nasty scar. Best corrected vision was, well, with vertical sills. And this is how it looks. It's a nice scar. He was told by 4 different clinics that his only option is some sort of a transplant, maybe a PK or a DALC or something, and he couldn't do dural sutures anymore because he didn't have stereo vision. So I said to him, "No, I think we can fix it." So this is how the topos look. It's really a nice scar. So as we talked about the gradient of that ectasia, it was 3 diopters per millimeter. Here it's almost 7. 42 microns of elevation change over a millimeter. And this is how it looks on retroillumination. You can see the bend of light, and on a 2 millimeter pupil, his vision quality was just unbearable. So we ended up doing a wavefront-guided TPRK, and it took 54 seconds because of the super speed. And this is his vision afterwards, with +3, -4. Unaided was 20/100, but aided 20/20. So what happened? Well, the topos really changed because we really smoothed it out as much as we could. And the difference is now less than a diopter per millimeter, and in elevation it's 7. So he really got a better outcome, but not because of the laser on itself. If you look at the side-by-side view, this is the elevation before and after. You can see that it's quite a nicer look. But this is the screen that really tells the whole story. It's a huge difference. 14 diopters increase on one side with a 13 decrease on the other. But how did he get thicker? He ended up having 100 microns more over the skull than before. Here comes our friend, the epithelium. The epithelium doesn't like gradients. It likes smoothness. So by lowering the other side, the epithelium filled up that hole and allowed him to have a better visual outcome. It took him about 2 to 3 months to fully remodel before this image was taken. Thank you.